Dr. Clay, you gave us a great bio with a lot of personal stuff that I loved. Is there anything else you'd like them to know about you before Daniel dives into the questions?
Well, I mean, you guys asked so many. I mean, well, all the questions that I've got here, we could talk for a day about a lot, about these things. But I think the only thing I would say is I'm still. Sometimes I run into other physicians who say, "Oh, if I knew then what I knew now, I wouldn't do this." And I just, even if I knew everything that I know now, I would still do this. This is, there are bad days. Everybody has bad days. But as a career, as a way to spend my life, I can't imagine that I would be happier doing anything else. So that's the only other thing I would say.
Awesome. So I guess we can get started. We have, as Dan alluded to, we have this long list of questions that you all sent us ahead of time. So that's great. And we can dive into those. I want to get through as many as possible since those are the questions we have. If anything comes up and you want to ask a question, if you're interested in something, again, feel free to type it in the chat or just unmute and interrupt me. It's no big deal. We just want to really make this as informative and helpful to you all as possible. So Dr. Clay, we can sort of get started on this list, but you mentioned you had a pretty interesting experience at Feinberg. You were singing and you were doing all these other things. What was it like to be involved with so many things outside of medicine as a medical student?
Yeah, so I mean, one of the things that the honors program that appealed to me about the honors program, which doesn't exist anymore, right? We don't have that, but as long as I kept a reasonable average, I could explore lots of other things. So even in undergraduate, I took graduate classes in archaeology. I really took a lot of unusual classes because I was from a small town north of Chicago, Waukegan, Illinois, and I didn't have a lot of experiences, and that was my chance to do that. So, now it sounds like exploring singing and working during medical school, but I did it because I needed the money. My parents are teachers, and I didn't have a lot of money, and I needed to do those things to pay the bills. And the thing about singing in bars is you work for tips, and if you're any good, you can make pretty good money. So as opposed to working in retail, which is kind of the other option. And then I guess what it really did is it helped me keep a balance because and a lot of the other questions, there were a number of questions about balance. And I think the fact that I came into medical school and knowing that could not be the only thing I did, that I had to make some money some other way, finding a way in medical school to balance those responsibilities wasn't a bad skill, wasn't a bad life skill to have going on, because as you've asked in other questions, throughout life, you're going to have family and children. If all you do is work, then it's really easy to get burned out. If work is going badly, then you don't have anything to go to lift that. And so singing and working during medical school, again, gave me the skills to keep doing that all along the way. That's enough.
No, that's great. I think, at least speaking for me, not all the M1s, but a pretty common topic of conversation is like, how do you keep in touch with the things that you sort of love to do, while also taking on this massive wave of responsibilities and information that you now have to take care of. It's I guess probably the toughest part of the transition to med school, at least for me.
Yeah.
And then the next question is also with regards to your experience in med school, but do you have any advice for students exploring and refining their interests as medical students with regards to what field they want to go into?
I don't think I really, so when I started medical school, in high school, when I applied to the honors program, I was really at the time driven by a wonderful surgeon I had met at the VA in North Chicago, and then watching MASH, so I wanted to be a surgeon. And when I got to medical school, I realized that that wasn't what gave me joy. What gave me joy was spending time with the patients while they were awake. I wasn't really a procedure driven person. And that's actually an interesting thing to figure out. Are you somebody who, where what gives you energy? Because part of being a physician is day after day, you're putting out a lot of energy. You're faced with people who are sick, who are scared, who are anxious, who are angry. And so you're putting out a lot, and you have to find those things in your work, because you're going to be at work. Like today, I started at 7:30 and I got home at 6. That's not unusual. And, you've got to find what feeds you at work, not just what feeds you when you're not at work. And what I found was that I got a lot from the patients, and I didn't really get a lot of enjoyment out of, doing scopes or doing bone marrows or doing surgery. But there are people who really do. One of my best friends is a surgeon, and she likes talking to patients, and that's enjoyable, but she loves a complicated breast cancer surgery, and that just makes her happy. So that's an important thing to figure out as you go through as you go through the rotations. What things that you do during the day do you walk away from feeling energized by, and what things do you walk away feeling drained? And you have to find that balance in whatever specialty you pick.
I have a quick question on that. You mentioned that being with patients when they're awake, talking with them is kind of what you enjoy. I feel like being an oncologist is somewhat unique in the types of conversations that you're having with patients, maybe even the amounts of time you have with patients in those settings. So I guess I'm curious, what kind of drew you into that? I'm sure you're going to talk about that at some point. And I guess reflecting on your career, like what is still kind of like really driving you with those types of patient interactions?
Yeah. So again, you have to look at the time that you're in, and because what I say will be different for you. But when I was making these choices, when I took my boards for the first time in oncology, there were about 12 drugs. And most of oncology was about making the diagnosis and then helping people come to acceptance that they were going to die from that, and then they would die. At the same time, we were right in the middle of the start of HIV. It wasn't called HIV, it was called GRID, gay-related immune disorder. And so I actually was torn for a long time between ID, where there were some drugs that were interesting and helpful, antibiotics, but you also dealt with end-of-life issues, which is I'll talk about that a little later, which I found really have been a rewarding part of my career. And that was very true of oncology too. Some interesting drugs was kind of, you could do a little bit, but really it was about helping people come to terms with their lives. So that both of those areas ultimately were of interest to me. And I ended up in oncology actually because oncologists were some of the smartest people I met. And I really enjoyed being around them. They were also really thoughtful because they were dealing with people at the end of their lives. They were often pretty spiritual people. And now things have changed. And so now in oncology, there are, there's so many drugs. I just took my boards again for what would be the third time in all these years. And now instead of 12 drugs, there were, I don't know, 3,000. And it's very different. So I find that a lot of the younger oncologists are actually going into the field not interested in end of life issues. That has now shifted from oncology into the palliative care, hospice realm entirely. And most of the oncologists I'm meeting now are very interested in the science, in the mechanism of action of the drugs and all of the new genetic mutations, that's really driving the interest for those people. So what I'm going to say is I really liked the honesty. In a lot of parts of medicine, we don't always tell people the whole story, but in oncology, we really have to. We do informed consent in a much more detailed way than most specialties do. We, right from the beginning, there's a kind of, for many patients, there's an understanding that this isn't forever and that there is a natural ending point. People tend to be more honest. We have to be honest, and then in response, they're more honest, which I really appreciate. And also because it's a natural place for talking about what's important in life. And so even if somebody has, say, an early stage breast cancer and they're going to have some surgery and they're going to be fine, it's still the diagnosis of cancer, even an early stage, forces people to take a look at what their life is, what they want it to be, and to watch a patient take what can be a very frightening and scary diagnosis and use that to make their life better or to make different choices. It's just, I just am so honored to be part of that. That is, turns out to be one of the major reasons why I like to spend time talking with patients. Does that more than answer your question?
No, that's great. I appreciate the answer. And I'm just one quick follow-up. Do you find that you still have the opportunity as an oncologist to have those kind of discussions that maybe in some settings might be transferred to the palliative care physicians? Like, do you still feel like you can have that if that's what you find rewarding?
So in private practice, I know I said in my bio, I've done a lot of different things. I'm just coming back into academia now, but in private practice, absolutely. I mean, I took care of people from, like I said, from a stage 1 breast cancer to oh my goodness, you have metastatic pancreatic cancer and you're going to be dying in the next few weeks. So I absolutely continue to do that. And now what they've asked me to do, which I'm happy to do, is breast cancer, which is great. But they also asked me to take on 2 of the more difficult subspecialties, brain, which remains a very in those very few situations where they can have a complete resection of a relatively small tumor, it is just a matter of time. And so I do get to have those conversations. And I'm also doing some head and neck cancer work because they're kind of related. And it's often the same thing. So I end up having conversations about how their life's going to be without a larynx or without a tongue or whatever it is. And so I still have those conversations on a daily basis. And then this week, I'm actually I'm the physician in the hospital. I'm on consult services. So, this is the patients who are not doing well in the outpatient setting and they're hospitalized for something. And we had 5 different goals of care conversations today with people with myeloma, 2 myelomas, an acute leukemia, a small cell, and I don't even remember. But so yeah, still having them. Yeah. Daniel?
Yeah, so that was amazing. You actually knocked out a few
A
more.
bunch of them, yeah.
Yeah. If we want to talk about, you already mentioned it, but if there's anything else with regards to how you discovered Hem/Onc as the best fit for you, I know you talked a bit about that, but if there's anything you want to add to that, we can talk.
Yeah. No, I think what I tell the medical residents that I work with is, you'll go from field to field, rotation to rotation, and you will find, just like with college, where a lot of people find that they walk onto the campus and they know that's where they want to go. It's the same thing with your specialty. That often happens. You do a rotation and you think, wow, this is where I fit. Not always, but a lot of times, it's the patients appeal to you, the colleagues appeal to you, something just clicks. I do want to say what I dislike about the field.
That was my next question, so I'll let you go ahead.
Yeah. So, I mean, what I dislike, though it is a necessary part of medicine, and none of us are going to get away from that, but it's just the financial aspects of it. I mean, I'll prescribe a drug where the acquisition cost for the drug could be $12,000 per dose or more. That's not an unusual thing. So a little chunk, or sometimes a bigger chunk of every day for me, is spent figuring out, talking with my pharmacist. When I was in private practice, looking at profit margin on drugs, I really, really dislike that. But it is a part of our field, I think, more than many, just because of the drugs. I mean, we make our profit as in private practice off of the drugs. So it's just a reality.
Yeah. Well, there was one question about specifically your internal medicine residency. So if you want to talk about that, your experiences and training, and then also the fellowship.
So I started, I knew I wanted to be in private practice. I knew at that point, I did not want to stay. I didn't want to do research. I didn't want to be an academic person. So I picked a residency that was community-based, and that was they were making internists to go into community practice. And I really enjoyed Bay State Medical Center. I was there 2 years. So that's in Springfield, Massachusetts. And it was a good program. I learned a lot. Again, a different time. There were no hour restrictions. It was a different time. But when I've been in touch with people who are still there, that program is still pretty strong. And then I left there because I met my husband, and we moved to Los Angeles, and I finished up my residency at a UCLA VA program. And again, that was, I think, where you go, if you're going to be an internist, and if that's your endpoint, then it really matters that you be at a place that you're going to be able to learn as much as possible, because the trouble with internal medicine is you're expected to know a lot about a lot of things. And picking a place where you feel like you're going to get that kind of education, I think, is important. If you're planning to go on to something else, then I think it becomes more important that you pick a place that's going to allow you to, like for oncology, for example, nowadays to get an oncology fellowship, you really have to be actively involved in research. So to be at a small internal medicine residency program where you don't have those opportunities is going to make it more difficult for you to get into fellowship. So it's I think you have to go into internal medicine or going into whatever residency you're going into with some sense of where you want to go from there, what the next step will be. And that's really, that's something to talk about at length with an advisor when you get to that point. My fellowship, I enjoyed USC very much, but again, I really knew I didn't want to be in academia. And once I got out to LA and kind of got to know the lay of the land, I knew I wanted to be at Kaiser. So, and Kaiser's was very sought after at that time. And the only way you were going to get hired is if you were one of their own. So I did my last year of fellowship at a Kaiser facility, really just to make sure I got into the Kaiser program. And it was weak, I have to say. My hematology fellowship was not very strong, but it did put me where I wanted to be. And, you know, you learn, if everything you learned in fellowship, you are in deep trouble because medicine changes so fast. You just have to keep learning all the time. I know you were saying that you feel overwhelmed by all the stuff you have to learn. Trust me, it never, ever ends.
Yeah, it doesn't help knowing that most of what we learn is going to be obsolete in 10 years anyway.
Well, you know what? Interestingly, the stuff you learn first and second year, the basic anatomy and pathophysiology really doesn't change that much. Yeah. I mean, like neurology, the brain has not really changed. And so learning all of the, learning all the parts of the brain, learning the cranial nerves, learning everything like that, that hasn't changed, and I use it every day. So, so learn lots first and second year.
Great. We do have another question, I guess, moving back one step. What are your thoughts on how the expectations for medical students and residents applying to programs has continued to grow more competitive since your time in school?
Yeah, my friends and I talk about that. Would we get into medical school now? I don't know. Yeah, I mean, and that's, I have to say, on a more national level, that's just horrible. I mean, there's a shortage of doctors, right? And the fact that we haven't increased the number of medical students and residency programs to match the growth of our population is just another travesty of the US healthcare system. But as I said, you really want to be thoughtful about where you want to be. If you want to be in community practice, then it is less critical that you be at some, fancy place. You want to be someplace where their main focus is teaching you. And if you're planning to go on to a pretty competitive fellowship, then you have to just suck it up and go someplace that has the opportunities there that will put you in the right place to get the fellowship you want. So you just have to be more thoughtful. I think because it wasn't so competitive, we could bumble around a little bit more. I think you guys have to be a lot more intentional about how you pick stuff.
I guess I have my own follow-up question to that. Do you think such a competitive and like sharpening system makes better doctors, or do you think it's just a sort of a different breed of doctor?
I'm going to sound like an old fart in a minute, but I think it is different. I think that when I was in training and when I went into medicine, there was much more of a sense that you were just going to be there however many hours it took, that they didn't care about your social life. They didn't care about who you were as a human being. You were a doctor and you were there to learn how to be a doctor. And then, but on the other hand, I think that there is also a sense of ownership of the patients that I'm not seeing as much now. And I don't, again, it's not a personal thing. It's an observation. I think when we went from being doctors to being providers was a language matters. I am not a provider. I'm a doctor. I don't agree with the with the doctor is the captain of the ship and everybody has to do whatever the doctor says. But I also don't, I think that it is different, the relationship with the patient that the doctor has than that the pharmacist or the physical therapist has. Their jobs are really, really important. But in the end, I'm the doctor. And what I see from my fellows, and again, I don't think this is wrong, it's just the way it is. At 5 o'clock, they're ready to go home. They're done, their shift is done, and they go home. And I can't do that. I go back to the hospital if I have to. I call patients at night. I give patients my email and my phone. So I think a lot has changed, and I don't know if that is for good or for ill. But and I've actually wandered off the question entirely. Sorry. Sorry about that.
No, that's actually great because you're wandering into work-life balance territory, which I guess we can go into the next question. But can you talk a bit about when you started a family and how you balance that with your medical career?
Yeah. So I'm going to come back around to, you're talking about all the stuff you have to do and balancing even your social life and things like that, your interests outside of medicine. You have to be willing to accept that you're not going to be perfect at anything you do. There was in my earlier life as a female in medicine, and I think this is still true, that women are supposed to be able to do it all. They're supposed to be great mothers and great whatever their jobs are, and great daughters to their parents, and great wives to their husbands. And the truth is that it doesn't work. And you just have to be willing to accept being good enough. There are people who choose not to, and I have an acquaintance who has been through several wives, and he is a phenomenal researcher. And the work he has done at University of Pennsylvania with CAR T cells and has changed our world in oncology and in other areas. But he sacrificed his life, rest of his life for that. I think if you make that choice, I think that's an okay thing. But if you don't want to make that choice, if you don't want to sacrifice your life for that, then you have to be willing to accept that you're not going to be the perfect parent. You're not going to be the perfect spouse. You're going to miss an occasional soccer game, and you have to just not beat yourself up too much. And you have to take a longer view. Like my girl, I have 2 daughters, and there were absolutely times where they were weeping and hanging on my legs and saying, "Mommy, mommy, don't go back to work." And it broke my heart. And they don't remember that. They have both turned into strong women who are seeking their own careers and their own role, their own place in the world. And they don't remember those things. I made it to enough concerts and enough soccer games that they don't remember all the times I missed. I do. I remember every time I missed something, but they're okay with that. And I found time to do things for myself, maybe not as much as I could have if I had been, managing a Starbucks, but it was enough. It was good enough. Yeah.
Amazing.
I have one question on that. Do you feel like going into private practice versus academia, I guess, how did work-life balance weigh into that decision, and what were the other factors?
Yeah. So being in private practice, seeing 26 to 30 patients a day, managing a staff, worrying about the profit margin on the drugs, all that kind of stuff, meant that I've made enough money that I can now go back to academia, where I make half the money I did. On the other hand, on a really busy day, I will see 15 patients, and I get to spend more time with them. And that's really nice. So I'm glad I did private practice. I'm glad I learned a lot of skills about managing a business that are now that I'm back in an academic setting, people listen to me in a different way, because I can speak at conferences. I can speak at meetings to the business side of oncology. And that gets me heard in a different way than if I'm just another academic person trying to push their own agenda of what they want to accomplish with their careers. So, and I don't think I would have done it the other way. I think I did enjoy being in private practice. I enjoyed being in charge of everything. But now I'm actually happy to go home at the end of the day and not have to worry about who's shoveling the sidewalks and who's turning on the lights and things like that. So I think the academic people do have better quality of life. They absolutely, I mean, they complain constantly about how busy they are, but in the end of the day, they do go home at 5 o'clock, and there is somebody covering, there's fellows and residents covering overnight. Whereas in private practice, it was me, So it is a better quality of life in academia. Yeah. Again, they're different. They're just different. And it really depends. Over the course of a 30-year, now it's going to be more than 30-year, I think it's finding those different chapters in life and enjoying them as they come. I see somebody else's face pop up. Hi.
Was that me?
Yeah, it is. Did you want to say something?
Yeah, it was a sort of follow-up question about that because I'm actually very confused about academic medicine because especially at a place like Northwestern, it's just massive. And it
Mhm.
seems like academic medicine could mean anything from like you don't see any patients whatsoever and you're just doing research to um, it seems like people who are just all clinical. And I was wondering if you could kind of explain your sort of place in academic medicine and help us make sense of it.
Yeah. So there are places like Northwestern or here in Philadelphia, like Penn, where there are people doing bench research, right? And who never see a patient. And that is in a bigger place like Northwestern, there are definitely those people. At a place like Cooper, where I am now, there's there's medical school, there's residents, there's fellows, there is active research going on, both bench research and to a small degree, but more clinical research going on. People are expected to write papers. They are publishing on a regular basis, but the funding for somebody who is doing solely bench research, their salary is got to be supported by something, and it either is a grant. It's a grant. They're grants of some kind. So in addition to doing whatever work they want to do, they have to be grant writing, or they have to have an endowed chair or something. In a place like Cooper, we're doing research. There may be some small grants, but the bulk of our financial well-being comes from seeing and billing insurance, seeing patients and billing insurance companies. So yeah, you're right. It's a wide range of things. I think when I say academia, I think in broad terms, it is organizations where the education of the next generations is a central part of what they do. So I do see patients every day, and but I am expected, and I enjoy having fellows and residents and medical students with me in that process. In private practice, I didn't. I mean, I occasionally would have somebody come hang out with me for a while, but that is one of my main focuses now. So I think that's the big difference. Does that help? Does that help?
It does. So it's like the kind of what it's either what you're saying is teaching is like at the core of it, and that's what.
Yeah.
Okay.
Yeah. I mean, private practice is seeing patients and generating bills. And there's a lot to be said for that. But at Cooper, I absolutely do not bill enough to pay my salary. So what I do as a teacher and the money that we get from all of that for the university helps pay my salary.
Awesome. Well, I think we have a couple more questions that about work-life balance that I'm just going to combine. So we talked about a few of them, but do you have any advice for continuing your passions and interests outside of medicine? And then also, are there any non-negotiables with regards to your work or personal life? And how do you sort of draw that line, and maybe how do you enforce it?
Yeah. Ooh, yeah. So I say this to patients all the time when they say, "Oh, I can't quit smoking," or "I can't do this," and I say to them, and I'm saying it to myself at the same time, which is, no one is sticking a cigarette in your mouth. Yes, you can quit. You just don't want to quit. With exceptions. I mean, people pretty much do whatever is important to them. And if something's important to you, if you feel that that's a non-negotiable thing, whether it's your physical health or your family, or, you know, spending a month or 2 months every year doing volunteer work in Ecuador, whatever it is, if you decide that it's important to you and you make that clear to your partners, to the institution you're working for, people will lay guilt trips on you regularly. You know, your children will make you feel guilty for going to work. Your work will make you feel guilty for going home to your sick child. That's never going to change, because you have all of these competing interests in your life and in your time. And that's not unique to medicine. That's in every part of life, you know, unless you live in a cave by yourself. So it's deciding for yourself, what are your priorities? And you may have to give up things. Maybe you can't go for 2 months to do volunteer work, or maybe you and your spouse switch off soccer games, or, you know, it really is about being intentional about what is important to you. And that means you may give up some things, you know, but again, if you've got the right balance between enough exercise, enough family time, enough attention to work, there will always be a tension. But if you are clear in your mind about what is important to you, then people will push you and pull you, but you just have to be firm. One of my and it never changes. People will always try to guilt you into doing other stuff, and you just have to be firm.
If anybody has any other questions, I think we're at the 50-minute mark. So just shout out. Kayla, it sounds like you might have one.
Oh, I just had a question going back a little bit. When you mentioned that you often give your email or phone to patients and you don't subscribe to, you know, just going home at 5. And I was just wondering if you felt that for you that like increases your work satisfaction, even though you're, you know, spending more time at work.
I think it does, in that my patients rarely abuse it. I try to be careful about who I give it to. I don't give my number to someone who's clearly crazy, and there are plenty of people who are. So, but at the end of the day, being able, if I feel like it makes the patient less anxious to have my number, what almost always happens is that they never call. And it's just the knowing that they could, if they needed to, calms them to a place where it really works out better that way. It's been very rare. I mean, very rare that I've had a patient abuse that. And so, yeah, it does. It does keep me connected. Now, I do have I do have some firm lines in that. I have a good friend who's a pediatrician who, when she was really involved in her patients' lives, she went to their birthday parties and their graduations. And I have always needed there to be a line between their lives and my life. So I didn't do that. She did it with a fluidity. She did it with ease. And I have always wondered if that meant that she had no borders, you know, no boundaries. And, you know, that was a problem. But she's always been really happy with that approach. And her patients knew where she lived. They came by. I I think it's what you're comfortable with. Yeah. Other questions, Daniel, that you think are important?
Yeah, well, there was, I think we've knocked out most of these, but is there something developing in your field that excites you? Something on the horizon, maybe?
Well, I mean, yeah, oncology, I don't know that I'm going to see this, but I'm hopeful that the day will come where no one will have to give chemotherapy anymore, that it's all going to be, you know, genetically driven immunotherapies. And it's getting that way more and more. In that for almost all of my patients, while I might give them chemotherapy, I'm just as likely to offer them some kind of targeted agent, whether it's HER2 targeting or hedgehog pathway inhibitors or, you know, whatever it is, but there's more and more of that. And that is what is so exciting, so that we will stop being breast cancer specialists and lung specialists and GI specialists, but it will all be about, okay, what's the driver mutation here? And what's the drug we need to give for that driver mutation? Instead of just throwing bombs at the poor people and killing everything in sight, which is what chemotherapy is, right? It's just like dropping a bomb. And that's what excites me. And that, I mean, that's actually what excites all of us. We sit there at conferences, we get these Foundation One or Caris, you know, looking at these mutations. Everybody gets so excited when there's a mutation that we can target, and that's it. That's the one I'm hoping that before I finish my career, that most of my treatments will be targeted like that and not chemotherapy.
So there is one, I guess, last question on here. You sort of mentioned you don't know if you would have gone from academics to private practice, but you went from private practice to academics.
Yeah.
Is there anything you wish you had done differently in terms of your career path or training or sort of how you got to where you are today?
Yeah, I'm not good at looking back at things. I'm very much, but my husband would say that I put up with bad partners for longer than I should have. I had, for most of my private practice career, I had just wonderful partners, and then there were changes and things. And I got into a rut, not a rut. I loved my patients and I loved my staff, and my partners were changing around me. And my husband would say that I should have left 5 years before that. So, so that's the only thing I think I would have done differently. And that has to do more with not medicine, but with interpersonal relationships. Because a partnership is very much like a marriage. And if you do go into private practice for whoever does that, you really need to have a prenup, and you need to have a good contract, and you need to have lots of communication as the years go by. And that's that's the only thing I would have done different. I would have probably stepped out a little sooner.
Awesome. Well, I think that does it for most of the questions that you all submitted ahead of time. Does anybody have any questions now that we've heard all of this beautiful wisdom?
I was interested in how you got into brain oncology, because I think of that as like often the stuff that like oncologists or people from IM don't touch as much. And it's more like,
Yeah.
like a lot of neurologists.
Yeah. So most of the people doing this are come from the neurology side. You're right. And I backed into it. So in my private practice, a strong neurosurgery team joined my hospital, and nobody else wanted to do it. And the neurologist didn't want to do it. So I said, sure, I'll do that. And then when I left my private practice, I had planned to take a few months to kind of find my way. And I ended up going to a case. I didn't even talk about this because it's a few paragraphs in my life, but I ended up going to a Case Western hospital in Cleveland and to help out. And while I was there, the neuro-oncologist went out on maternity leave and they said, will you do this? And I said, sure. And then when I realized that I wanted to be in Philadelphia, and Cooper offered me this job, they said, hey, we hear you've been doing some brain stuff. Our brain person is retiring. Will you do this? And so I ended up there. But you're right. It is often the neurologists who do it. And I would, at Northwestern, I would guess, and certainly at Penn, the neurologists have the support to do it well. But in smaller facilities, the neurologists don't have the supports in place to do chemotherapy. And so it does often fall in smaller hospitals to the oncologists to be doing that. And again, it's a kind of in my wheelhouse to be dealing with people who are nobody else wants to, near the end of life. I have a lot of patience for them, and not everybody does. It's actually really odd too, because in the rest of oncology, the body is failing, but the mind is intact. And in neuro-oncology, their bodies are fine, but their brains are not there. And you have to have tremendous amount of patience, kind of like with dementia or Parkinson's, things where that's hard on the families as well. It's a challenge, but that's how I backed into it. But that's how life is, isn't it? You just got to keep an open mind and an open heart, and all kinds of stuff will happen to you. And most of it's pretty good.
I think that's a perfect way to end right there. Wonderful. Well, what a great conversation, everyone. And I just want to thank you all for taking the time to be here. And for the students, I want to encourage you guys. We have 4 more APFs. It's a busy month for alumni physicians of Feinberg. We've got Dr. Deitcher on Thursday, and the invite has gone out on that one. That's a great opportunity. Next Thursday, Dr. Shireen Fakran from Cook County Hospital. She's a pulmonologist, critical care specialist. That invite will go out soon. It's a great one. And then on the 23rd, Julie Melchior from Colorado, orthopedic surgeon and hand specialist. And the final one of February will be Connie Saver-Price, who is a infectious disease expert who was mentored by Dr. Anthony Fauci. So some pretty great opportunities. So I want you guys to consider joining us for those as well. I want to say a special thank you to Daniel for doing a great job of moderating the conversation, and especially Dr. Clay. We're so grateful to you for not only finding the time, but just the way you share yourself so fully and so genuinely. It's really special, and it's no coincidence that I thought of you when I was programming this series. So thank you so much.
You're welcome. And you can share my email if anybody has questions. If you would share my email, that would be great.
I'll be happy to do that. And I'll share the recording with you guys in case you want to revisit it or share it with any friends. And thank you so much. Everybody have a great rest of the evening.
You're welcome. Thank you so much, guys. Take care.
Thanks, everyone.
Thank you.
Thank you.